Good morning. We'll continue to examine patient with heart pathology, and today we'll stop on heart auscultation. To talk about heart auscultation, first of all, I want to remember you that main our heart structures are four valves, which regulate blood flow, and you must clearly understand what valve must be opened or closed in any period of heart activity. We distinguish two periods of heart activity, systole and diastole. During systolic period, blood ejected in lesser and greater circulation. During diastolic period, blood hold into the heart chamber. To auscultate the heart, we must differentiate two positions. True anatomic position of the heart valves, we are talking about projection of the heart points, and points where this valve will be auscultated. First of all, we'll start on the anatomic position of the heart valve, from which we'll put perpendicular on the heart chest. If we are talking about mitral valve, which separate left atrium from left ventricle, it's projected on junction of the third rib to the left edge of sternum. Junction of the third rib to the left edge of sternum. Anatomic position of mitral valve. Aortic valve localizes medium of the sternum on the level of third rib. Aortic valve, medium of the sternum on the level of third rib. Pulmonary trunk valve, second intercostal space to the left of sternum. Pulmonary trunk valve, second intercostal space to the left of sternum. And tricuspid valve localizes on medium of line which interconnects third rib to the left with fifth rib to the right. Tricuspid valve, medium of the line which interconnects third rib to the left with fifth rib to the right. We distinguished four valves which regulate blood flow. And first of all, we are talking with you about its true anatomic position, from which we'll put perpendicular of the chest. And if you attentively see on this picture, you see that all valve localizes near it third rib. And if we'll auscultate this point in its anatomic position, we cannot differentiate where is localized pathology because all sounds will be mixed. To help yourself, we'll distinguish auscultative point, will separate artificially of the valve from its anatomic position and auscultate them in definite point. Mitral valve, you remember, anatomically it localizes junction of the third rib with left edge of sternum, but it will be auscultated on the heart apex, which is fifth interspace medially from left midclavicular line, because process activity of mitral valve is transmitted along left ventricular muscle, except third. costosternal junction, it will be auscultated fifth interspace heart apex. Aortic valve, instead, medium of sternum on the level third rib will be auscultated second interspace to the right of sternum. Second interspace to the right of sternum. Pulmonary trunk valve will auscultate in its self-anatomic point, second interspace to the left of sternum. And tricuspid valve will auscultate slightly lower its anatomic position. You remember, it's localizes medium of line which interconnects third rib to the left with fifth rib to the right, approximately here, but will auscultate it on the base of the void process. You see, we artificially separate position of valve, and our ear can differentiate pathological process because we'll auscultate only one valve. And sometimes we'll use additional Botkin Erb point. Botkin and Erb, there are authors which prescribe this point. It's localizes junction of the third fourth rib to the left eight of sternum, and it is used in case pathology over aortic valve. If we'll reveal any pathology over aortic valve, we'll obligatory auscultate additional Botkin Erb point. Third fourth interspace along left eight of sternum. Again, let's compare anatomic position, projection, and auscultative point of the heart valve, because this question obligatory will be given on exam. Mitral valve, projected junction of the third rib which left eight of sternum, auscultated heart apex, fifth intercostal space medially from left mid-clavicular line. Aortic valve localizes medium of sternum on the level of third rib, auscultated second interspace to the right of sternum. Pulmonary trunk valve projected and auscultated same point, second interspace to the left of sternum. Tricuspid valve projected medium of line which interconnects third rib to the left with fifth rib to the right, auscultated base of the void process. You see impossible auscultation of the valve in its anatomic position and optimal auscultative point which separate all pathology. We remember that only one valve, pulmonary trunk, auscultated in its anatomic position. It will be needed later when we'll talk about some pathology which may be revealed over heart auscultation. Let's stop on order of heart auscultation. We'll auscultate the heart with definite order. First of all, heart apex, mitral valve. Then aorta, second interspace to the right. Pulmonary trunk, second interspace to the left. The void process, tricuspid valve. In some countries may be used other order. First of all, apex, the void process, then aorta, pulmonary trunk. But it's not difficult to change when we'll work as doctor. Now we'll study order which used in more countries. Heart apex, aorta, pulmonary trunk, xiphoid process. Mitral valve, aortic, pulmonary trunk, tricuspid valve. Point where auscultated heart mitral valve is called heart apex. Point auscultation aorta and pulmonary trunk, heart base. Because on exam may be different question. Auscultate any valve or auscultate any point. When we'll ask auscultate heart apex, it's only mitral valve problem. Heart base, both aorta and pulmonary trunk, or maybe separately, only aorta or only pulmonary trunk. You must be attentive when you will answer on exam. What is purpose of heart auscultation? Because you remember that any our action is made with definite purpose. During heart auscultation, first of all, we'll count number of auscultated sounds. Usually, we'll auscultate only 2 sounds, which are corresponding heart activity, systolic and diastolic. Some case we can hear 3 sounds about which we talk later. Assess number of the auscultated sounds. Then we'll assess the rhythm, which may be regular or irregular. Depending on rhythm, we'll count heart rate. We'll remember principles of rate calculation. If rhythmic contraction, we can count heart rate during short time, 10, 15, 20 seconds. If arrhythmic, only full minutes. Usually, heart rate varies from 60 to 80 beats per minute. Then we'll give characteristic of sound depending the loudness and the duration. After that, we'll pay attention on some additional sounds which may be heard between main heart tones. This pathology is called heart murmurs. After that, we can formulate full conclusion. Today we'll stop only on characteristic of the heart sound. Next lecture will be about heart murmurs. To characterize heart sound, we must remember and study mechanism of the formation. And first of all, you must understand what do you hear during systolic or during diastolic period. Activity of what heart structures is audible. First sound, systolic sound, will hear activity of the heart, audible activity during systolic period. Let's remember physiology. What process does appear during systolic period? First of all, we'll hear vibration of the atrium from which contraction is started systolic period, which is atrial component of the first sound. Then atrioventricular valve closed. We are talking about valvular component because vibration of the closed valve is audible. After that, excitation and contraction of ventricle will have vibration of heart muscle, muscular component. And during ejection of the blood, we will have vibration of the aorta and pulmonary trunk, vascular component. First systolic sound is formed from four components: atrial, valvular, muscular, and vascular. But intensity of the sound mainly depends from activity of the valve and muscles because it's more audible process closing of atrioventricular valve and vibration of contracted ventricular muscle. And if our stethoscope over heart apex will assess activity of the left heart chamber and mitral valve. If our stethoscope over xiphoid process will assess tricuspid valve and right ventricle problem. First heart sound is formed due to audible vibration of the atrium, valve, muscles, and aorta or pulmonary trunk. Intensity of the first sound depends from activity of atrioventricular valve and ventricular muscles. If you understand this process, you can easily explain why intensity of the first sound decrease or increase due to increased or decreased activity the valvular and muscular components. Second sound, diastolic sound, appears due to audible process during diastolic period. It starts from closing semilunar valve to prevent comeback blood flow, valvular component, and transmitted vibration of the vessel, aorta or pulmonary trunk. Second sound is formed from two components, vascular and valvular. Main from them is valvular. Other word, intensity of the second sound will be dependent from activity closing of semilunar valve over aorta or over pulmonary trunk. Then we must decide how can you differentiate what sound is effective. You must clearly understand what sound is corresponding first or second sound. To differentiate heart sound, first of all, we'll pay attention on pauses between them. Systolic first sound appears after long diastolic pause. Diastolic second sound appears after short systolic pause. pauses between sound. After short pause, second sound. After long, first sound. But in case of tachycardia, when the cardiac rate accelerated, diastolic period shortening and sometimes becomes same with systolic. How can you differentiate sound in this case? We'll compare heart contraction with pulsation carotid artery. I want that you remember because it is obligatory action. You put stethoscope over heart auscultative point, left hand obligatory place on the neck to palpate carotid artery. With this action, you show that you clearly understand and differentiate first and second sound. Sound which appears simultaneously with vibration carotid artery will be first, because systolic sound will feel vibration of carotid artery or its pulsation because ejection of blood, which is corresponding of systolic period, and give first sound. We can assess and give characteristic of the sound depending of points the auscultation. Other word will characterize any heart sounds over the points where prevalent the components. First sound is characterized over 2 points, over heart apex and base of xiphoid process. Because we remember, main components of the first sound is valvular, atrioventricular valve, and muscular. Beta, vibration of valve and muscles, is heard over mitral and tricuspid valve auscultative point. And I want that you remember, when we'll ask you about characteristic of the first sound, you'll auscultate heart apex and xiphoid process base. If you auscultate this point, you pay attention on intensity and other characteristic only first sound. What is normal intensity of the first sound? We are talking about normal intensity of the first sound when it is heard 2 times louder comparing with second sound when our stethoscope over heart apex and xiphoid process. Because we remember, in every heart point we'll hear 2 sounds, first and second. But intensity of the first sound must be 2 times louder than second one if our stethoscope over heart apex or xiphoid process, because there are point formation components of the first sound. First sound increased when its intensity more than 2 times louder comparing with second sound. When can it be? Over heart apex, first sound increased in mitral stenosis, which is heart defect, which characterized with narrowing mitral orifice, and in case of tachycardia. Why? In this pathology, first sound increased, heard louder, because intensification the muscular components due to decreased blood volume into the left ventricle. Heart muscles easily contracted and eject small blood volume. Why is it appear in this pathology? In mitral stenosis, filling of the left ventricle decrease because through the narrowing mitral orifice, blood flow restricted and diastolic period not enough to completely fill left ventricle with blood. Some blood delayed above left ventricle. In case of tachycardia also, heart ventricle cannot be completely filled with blood because shortened diastolic period, time during which left ventricle filled with blood. Only one cause increased force sound over heart apex, which is decreased filling of the left ventricle with blood due to mitral stenosis or tachycardia, which gives intensification muscular component of force sound. Same process will be always a forward process when will be intensified muscular component of the force sound due to easy and active contraction of right ventricle. But it will be caused tricuspid orifice stenosis and tachycardia also. First sound decrease. We are talking about weakness of the first sound. And again, first of all, we'll pay attention on the heart apex, problem with left ventricle and mitral valve, because it's more often involved in pathological process. If you understand left chamber problem, same process into the right heart chamber, but problem with right ventricle and tricuspid valve. We are talking about weakening of the first sound when its intensity same or less than 2 times comparing with second one. No 2 times deviation between intensity first and second sound. They approximately same. When can it be? It can be due to affection of component of the first sound. We remember about 2 main components for sound, valvular and muscular. Problem with valvular component. Mitral valve cannot be completely closed due to the shortening, which is heart defect, which is called mitral valve insufficiency, campenome and pathology, or in some books you can meet its other name of this heart defect, mitral regurgitation due to pathophysiological problems, because main function of mitral valve to prevent comeback blood flow during systolic period of heart left ventricle contraction. Blood go only into the opened aorta. In this case, blood go in 2 directions, normally into the aorta and come back through the unclosed mitral valve. And this heart defect has 2 names, depending on pathomorphology. mitral valve insufficiency. Depending on pathophysiology, mitral regurgitation. Process closing of mitral valve becomes unaudible because they're not closed. No valvular component. Minus one component, decreased intensity of first sound. But heart defects not often problem now because we'll know how completely and effectively to treat inflammatory process nearest mitral valve and mitral orifice, otherwise rheumatism, and prevent formation of heart defect. More often, first sound weakened due to affection its muscular components, because problem with heart muscles it's more often pathology. Let's see what causes disordered muscular component. First of all, when the left ventricle overfilled with blood, we are talking about increased diastolic filling of the left ventricle because difficulty eject large blood volume. It appears in two heart defects because abnormal combat blood flow, mitral valve insufficiency and aortic valve insufficiency, or we remember they are the name mitral regurgitation and aortic regurgitation. Combat blood flow, overfilled left ventricle with blood. Affection of the heart muscles. It may be due to the inflammation, myocarditis, due to its damage and necrosis, myocardial infarction, and abnormal growth of connective tissue, which decrease elasticity of the heart muscle and restrict their contractive ability. Cardiosclerosis. This problem more characteristic for left heart chamber. Next problem is hypertrophy of the left ventricular muscle, which first of all appeared as compensatory response to intensified contractive ability. Later, it's decompensated due to dystrophic process because not adequate blood circulation, not adequate coronary circulation into the hypertrophied muscles. Left ventricle hypertrophy due to increased blood pressure in greater circulation, arterial hypertension, and in case of heart defect, aortic stenosis, because needed more intensive force of contraction to eject blood through the narrowed orifice to compensate systemic blood flow. You see three problems with heart muscles. It's damage, affection, it's hypertrophy, and diastolic overloading. Same process will be over the xiphoid process, but we will talk about tricuspid valve insufficiency or tricuspid regurgitation due to damage of valvular component. We can say about tricuspid regurgitation or pulmonary regurgitation when right ventricle will be overfilled with blood, and we are talking about pulmonary trunk stenosis or hypertension and less circulation due to hypertrophy of the right ventricle. Second sound characteristic, we remember it is diastolic sound, which main component is valvular components, activity of semilunar valve, and will give characteristic of the second sound due to auscultation of heart base. There are aorta and pulmonary trunk. Second in the space to the right or left of sternum. When we'll auscultate heart base or separately aorta or pulmonary trunk, we'll pay attention on intensity of the second sound and gives only its characteristic. Normal intensity of the second sound over aorta and pulmonary trunk when it will be heard 2 times louder comparing with first sound. Same correlation. 2 times. It's very easy, remember. But when our stethoscope overhead apex and xiphoid process, first sound 2 times louder than second. We'll auscultate aorta and pulmonary trunk. Second sound becomes 2 times louder. Will be changed only correlation between first and second sound depending position of our stethoscope, depending of auscultative point, will be different conclusion. Apex and xiphoid process will give characteristic first sound, which normally 2 times louder than second. Heart base, aorta and pulmonary trunk will give characteristic second sound, which must be 2 times louder with first. Let's see. Problem in which it will be changed. Second sound decreased when its intensity less than 2 times comparing with first one. Same principle. It may be only one cause. Problem with valvular components. First of all, it is heart defect, aortic or pulmonary trunk valve insufficiency, or other word aortic or pulmonary trunk regurgitation. When the semilunar valve shorten and process of the closing becomes unaudible. No adequate valvular component. Intensity of the second sound decreased. Next problem, which is decreased blood pressure in systemic or lesser circulation, because intensity of the closing of valve depends from blood pressure. And if the blood pressure decreases, valve will be closed quieter. Intensity of the second sound decreased. Problem with valve is anatomic defect, aortic or pulmonary trunk regurgitation, or decreased blood pressure. Second sound increased when it is heard more than 2 times louder comparing with first sound. Why? Because semilunar valve closed more intensively. First of all, it is increased blood pressure in systemic over aorta or lesser circulation due to arterial hypertension or atherosclerosis. If the second sound increased over aorta, increased blood pressure in systemic circulation is called arterial hypertension or atherosclerosis. If you remember, last lecture we said with you about pathological collection of the cholesterol into the wall of the blood vessels. As a result, its elasticity decreases and vessels remember metal tube. And if the blood push on this non-elastic wall will hurt, increase second sound. Over pulmonary trunk, second sound increase due to increased blood pressure in left circulation, which appears due to mitral heart defect, mitral stenosis, or mitral regurgitation, because in both cases problem with passage of blood flow and needed intensify activity of left atrium, which is possible due to increased pressure in left circulation, and chronic lung diseases, because in this case elasticity of the lung decreases and gas changing becomes difficult through the affected alveolar wall. To intensify this process, compensatory increased pressure in left circulation. Second sound increase due to increased pressure in greater circulation, or which is intensified over aorta, or lesser circulation when it's intensified over pulmonary trunk. Intensity of the second sound over aorta and pulmonary trunk must be assessed from other position. First of all, we'll assess separately only over aorta, then only over pulmonary trunk. Then we'll again come back to aorta and pulmonary trunk to compare second sound over different point. And normally, second sound over aorta must be same intensity with second sound over pulmonary trunk. Not mixed. You auscultate aorta to compare intensity of the second sound comparing with first. Then over pulmonary trunk, same order. Then we'll again come back to aorta and pulmonary trunk, but with other purpose. We'll pay attention only on intensity second sound, and normally second sound over aorta and pulmonary trunk must be same intensity. I want that you understand this process, because whenever we compare first sound, only second sound. Why? Let's again come back to the beginning of our lecture when we said about heart projection and auscultative point. And I paid your attention only one point, pulmonary trunk, auscultated in its definite anatomic position. It shows that no artificial condition which can change intensity of the sound. All other sounds auscultated on distance from its anatomic position. As a result, its intensity artificially decreased. And primary, more loud second sound over aorta becomes same with second sound over pulmonary trunk, because it loses energy because auscultated on the distance from its true position. Second sound over pulmonary trunk not change intensity and auscultated same as appears primary. Why primary second sound over aorta louder? Because physiologically pressure in greater circulation and activity contraction of left ventricle higher than right. From this position, we cannot compare for sound because primary they different and on distance again becomes different. Only second sound may be compared. And when we'll ask you auscultate heart base, you must compare aorta and pulmonary trunk. Your conclusion must be about intensity of the second sound over aorta and pulmonary trunk, which normally must be same. If different, we are talking about pathology, which is called accent second sound. Let's explain why second sound over aorta and pulmonary trunk becomes different. Why will be formed accent of the second sound? Accent second sound over aorta when it is heard louder than over pulmonary trunk appears due to increased pressure in greater circulation. There are arterial hypertension or atherosclerosis of the ascent of the ostium of aorta. In this case, second sound over aorta will be louder than over pulmonary trunk. We are talking about accent second sound over aorta. Opposite correlation. Accent second sound over pulmonary trunk. We are talking about this problem when second sound over pulmonary trunk will be heard louder than over aorta. Second sound over pulmonary trunk louder than over aorta. We are talking about accent second sound over pulmonary trunk due to increased pressure in left circulation. There are mitral heart defect, mitral stenosis and mitral regurgitation, or chronic lung diseases, tuberculosis, pneumosclerosis, emphysema, all pathology which decrease elasticity of the lung. If you was attentive, you can see accent second sound over heart base tightly correlated with intensity of the second sound. If the second sound over aorta increase, it will be accentuated. If the second sound over pulmonary trunk increase, it also will be accentuated because causes increase and accent second sound are same. Intensity of the both heart sounds may be decreased or increased. It may be physiology or pathology. How can be differentiated? Physiology, problem which not connected with heart. As a result, heart works usually, but sound will be heard badly. But it is outside problem. As a result, correlation between first and second sound in different points will be normal. Over heart apex and xiphoid process, first sound will be heard louder. Over heart base, second sound will be heard louder, but both sounds will be badly heard. Or maybe opposite, very easy heard. We'll want to separate stethoscope because very loud sound. Intensity of the both heart sounds may be changed due to extra cardiac causes or due to problem with heart. If problem with heart, correlation between first and second sound will be disturbed, and more problem will be over heart apex. Let's see when intensity of the both heart sound decrease due to cardiac problem. There are diseases which affect heart muscle. Myocarditis, myocardial infarction, cardiomyopathy. No muscular component, first sound decrease. If contractility of the heart decrease, no adequate heart stroke, no adequate systolic pressure. Blood pressure also decrease. Muscular component decreased intensity first sound, blood pressure decreased intensity second sound. We see both heart sound will be decreased. Extracardiac causes. When the problem outside heart works normally, but on auscultation we badly hear the activity. No, first of all, there are patients with overdeveloped subcutaneous fat or muscular of the chest, patient with obesity or athlete. Or if the heart separated from the chest due to lung emphysema or left hydrothorax. But I'll again pay your attention. Extracardiac causes. Correlation between sound will be normal. First sound louder than second louder than third indefinite point. But both sounds are heard badly. And we needed to ask the patient hold breathing to exclude all other sounds and pay attention only on heart. Heart sound increases. No, usually both heart sound. Usually it is extracardiac causes. Thin chest wall. Heart tightly connected with chest. Or it may be due to diminish of the lung, sclerosis or atelectasis of the left lung first of all. When the heart pressed to the sternum because growth of tumor in posterior tridaspanium. It may be heard after physical or emotional overexcitation because more intensive heart contraction. Same problem appears in period of high fever, and it is characteristic for patients with thyrotoxicosis because thyroid enzymes control activity of the heart, and if its level in blood increases, contractive activity of the heart and arterial blood pressure will be increased. As a result, will be increased both first due to muscular component and second due to valvular component sound. Heart sound increase mainly due to extracardiac causes. Next question on which I want to stop today. If you remember, at the beginning of our lecture, I said you will give characteristic of the heart sound depending the loudness about which we said with you and its duration. Duration of the sound depends from activity conductive system because you now know first sound is formed from fourth component, but will not show every component separately because this process appears such fast: contraction of atrium, closing atrioventricular valve, contraction of muscles, vibration of vessels. Such fast usually it is during 0.1 second. our ear cannot separate all these components, and they will be heard and as one short hard stroke. Same process with second sound. Closing of semilunar valve and vibration of vessels appears immediately one each other, and our ear also will hear this component as one short stroke. When we'll listen only two short stroke, first and second sound, our conclusion will be hard sounds are clear. Normal duration. But if there's some problem with conductive system and some component delay, we can hear sound as widening, flat sound. No, to understand, you can compare sound when we push small plastic ball on the wall and ball for volleyball or football. Will be different sound. Will we push on the table with top of pen or with palm of hand? Different sound. Same mechanism will be heard on hard auscultation. Sound widen, it becomes flat. Or sometimes instead one, we can hear two short strokes. If the sound slightly widen it, we are talking about splitting. If more deep process in conductive system, and instead one short stroke, we will hear two short stroke, we are talking about reduplication. Each is normal hard sound, which will be heard as two short stroke because process which depends from conductive system is normal. Every component appears immediately, and process of heart contraction or relaxation is very short. Impulse delayed, mainly in AV node, will hear splitting, first of all, of first sound, because process closing of atrioventricular valve and contraction of heart muscles separated due to delay impulse in AV node. If this process prolonged, sound stop long, impulse stop longer, instead one stroke will hear two short stroke. We are talking about reduplication. Process may be with first sound or maybe with second one also. Splitting, when impulse slightly delayed and process contraction of atrium, closing of valve and contraction of ventricle slightly slower, duration of first sound prolonged. If the process more deep and impulse more longer stop in AV node or more slowly go along left ventricle, sound will be heard as two short components. We are talking about reduplication. It may be physiological or pathological. Physiological process appear due to asynchronous closure of the valves, mainly semilunar valve, during deep breathing. No, normally, will not ask the patient deeply breathe when we'll auscultate the heart. We'll give opposite direction, stop breathing, to separate lung and heart sound. But sometimes, no, for example, if you auscultate Spotman after physical exercise, patient breathing intensified short time. Or if patient with other problem with central nervous system, for example, deep Kussmaul breathing, you need to auscultate the heart. Maybe splitting or reduplication, first of all, second sound, due to increased pressure in the chest and asynchronous closing of the aortic and semilunar valves. Pathological reduplication of the fourth sound appears due to affection of conductive system. A problem with conductive system is called block, and first of all it is his bundle block. Problem with passage of impulse along bundle his branches or intraventricular block. Pathological reduplication of the second sound due to asynchronous closure of semilunar valve appears due to increased pressure in lesser or greater circulation, or also due to intraventricular or his bundle block. His is otter. You must remember, if duration of the first or second sound increases and each is heard longer or sometimes duplicated, first of all, we must find problem into the conductive system. Because if the impulse goes slowly, every component of the sound will appear later and may be heard separately. And last problem on which I want to stop today, it is amount of heart sounds. Its first characteristic, if you remember, about order conclusion of heart auscultation. Normally, we'll hear only two sounds because two periods of heart activity: systolic, first sound, and diastolic, second sound. Now we'll stop on the problem when we'll hear additional third stroke, which appears during diastolic period. And to understand this problem, you must clearly understand what process during diastolic period, except second sound, becomes audible. Let's again remember, systolic period, first sound, will hear vibration of atrium and ventricular muscles, atrioventricular valve, and large vessels. Diastolic period will hear vibration of semilunar valve and vessels wall. Second sound. Then diastolic process are notable because after closing of semilunar valve, second sound, process opening atrioventricular valve and slight vibration of the muscles becomes unaudible because valve, elastic valve, gradually open due to change pressure in atrium and ventricle, and blood go into the left ventricle. They not completely empty and vibration of the muscles are audible. When this process becomes audible, we'll hear additional heart sound. Other word, adventitious sound, which appear during diastolic period, which is audible process opening atrioventricular valve or audible vibration of heart muscle during filling ventricle with blood. Depending of problem, we'll distinguish two pathological rhythms with three sounds, gallop and triple rhythm. Triple rhythm may be heard only over heart apex because each is characteristic only for one pathology, mitral heart defect, mitral stenosis, and will show process opening mitral valve, which appears immediately after second sound. If you remember, I said you elastic valve opened unaudibly. In mitral stenosis, mitral valve becomes non-elastic due to pathological growth of connective tissue, which narrow with mitral orifice and increased density of mitral valve. Plus, if you remember, I said you to push blood through the narrow with orifice, pressure in left articulation and contractive ability of left atrium increase. To this problem, make process opening mitral valve audible because it's open with intensive force and blood, they not elastic, will hurt as opened mitral valve. And except two sounds, systolic and diastolic, will have additional heart stroke. Sound opening mitral valve. If you was attentive, I said you during mitral stenosis, through the narrow with mitral orifice, left ventricle cannot be adequately filled with blood. Inadequate filling of left ventricle intensified mitral muscular component of the left ventricle will be increased first sound. Triple rhythm characterized with loud increased first sound and additional sound which appears due to audible opening mitral valve. Gallop rhythm will show other process during diastolic period. Will show vibration of the heart muscles, which loses elasticity and non-adequately responds on the passage of blood. Will show vibration of the heart muscle. If it appears early at the beginning of the diastolic period, we are talking about pathological surge, protodiastolic sound. If it appears later at the end of diastolic period, when the left atrium actively contracted and push blood into the left ventricle, we are talking about fourth presystolic sound. If the heart muscles such weak that vibrate all period of the filling left ventricle with blood, will be heard third and fourth sound, but our ear cannot distinguish more than three sounds. We'll hear only three strokes. We are talking about mixed mesodiastolic gallop rhythm, which may be heard due to deep dystrophic process with the heart, cardiomyopathy, patient with myocardial infarction, and diffuse myocarditis. Severe heart diseases which affect left ventricular muscle. It loses elasticity and will show its vibration during diastolic period. If heart muscles affected, intensity of the first sound will be decreased. Gallop rhythm is characterized with decreased first sound over heart apex and additional heart stroke, which give protodiastolic, presystolic, or mesodiastolic gallop rhythm, but it may be differentiated only with instrumental method, phonocardiography or echocardiography. It cannot be differentiated during auscultation because our ear listen only 3 stroke. And we are talking about gallop rhythm because audible vibration of the weak heart muscle. And last slide helps you differentiate principal differentiation, gallop and triple rhythm. Because you put stethoscope, you listen 3 stroke. You must decide each is triple or gallop rhythm. How is it possible? Depending intensity of the first sound. If you was attentive, you remember in gallop rhythm, third stroke accompanied with decreased first sound because gallop rhythm it is audible vibration weak heart muscles, no muscular component, no adequate intensity first sound. Triple rhythm is characterized with increased first sound because non-adequate filling of the left ventricle of the patient with mitral stenosis will process opening mitral valve. To differentiate gallop and triple rhythm, when we'll hear instead 2, 3 stroke, we'll pay attention on intensity first sound. Third stroke accompanied with weakened first sound, we are talking about gallop rhythm because it is audible vibration of the heart muscle. Triple rhythm, third stroke accompanied with loud snapping first sound because we'll hear process opening mitral valve, patient with mitral stenosis. That's all today. It's very difficult process auscultation of the heart. Needed long time for training to differentiate loudness, especially splitting, reduplication, or additional heart sound. But will be practical classes and will be time to improve your knowledge. Thank you so much for your attention. Be healthy. Goodbye.